Good evening, Endometriosis Summit crowd. We are here tonight to talk about teen endometriosis, to talk about what to do if you think your teen has endometriosis, what can be done, and what can be done for those of you that have teens that already have endometriosis. We are live on Facebook and we are here on Zoom as well. I am welcoming tonight, of course, my Endometriosis Summit partner in crime, Dr. Andrea Vidali. He's waving. He was a little late, but he's arrived.
30 seconds.
And we are also welcoming this evening Dr. Lawrence Orbach. Dr. Orbuch, can you go ahead and introduce yourself?
Hi, I'm Lawrence Orbach. I am in practice primarily here in Los Angeles. I've been doing this for, I hate to say it, nearly 23 years now, which is kind of amazing to me. Taking care of endo patients of all ages, shapes, and sizes, and with varying presentations. I think personally, I find taking care of teens and adolescents the most promising to me, because you're catching people early on in the process and hopefully save them from those many years of suffering and the delay to diagnosis. I'm trying to battle the misconceptions out there among a lot of practitioners that, you should wait until you're older to deal with these problems, or wait until you're ready to have a baby, or some such silliness. So I think what we're all trying to propagate is the facts and the reality that you really want to tend to these problems earlier and kind of cut it off at the pass before it becomes a chronic long-term condition.
Right, and for those out there that don't know, Dr. Orbuch is half of a very important team, and also that team wrote a book which I would think is the Bible for a lot of people who are teens with endo. Can you tell us who your other team member is there?
So my partner, both at work and in life, is Dr. Iris Orbuch, and we have a book out called Beating Endo, and it's basically a compilation of our practice philosophy and kind of the what we do to help patients. That we realize that there was never any good reference or clearly explained format for both, mostly for patients and their family members and partners and also for all types of medical practitioners to use as a little bit of a guide to how to treat, not only treating the endo itself, but it's actually more focused on treating all of the coexisting pain generators that oftentimes are not addressed or kind of ignored or thought of as being unrelated issues that we have found and that we all know in this group are very common in endometriosis patients and really need to be treated in order to get people to feel the best that they can feel and to really address everything.
Right. So I think Beating Endo is a great place for the parent of somebody or the partner of somebody with endometriosis to start and also really understand the disease. In addition to buying a ticket to the Endometriosis Summit, which we are just about 10 days away from. Also joining us this evening is none other than Dr. Jeff Arrington from the Center for Endometriosis Care in Atlanta. Dr. Arrington, can you go ahead and introduce yourself?
Yes, so Larry, Iris and I, way back in the day, we both did our fellowship year during the same time. She worked with C.Y. Liu and Harry Rich up in New York the same time that I was working with C.Y. Liu in Chattanooga.
Right.
So we go way back, and really for the last 16 years, since completing that fellowship, more and more endometriosis, really right from the get-go. One of the tough things for me going on is I was kind of all by myself, the first one and the only one doing this sort of work in Utah. And that was a long road going forward. But it's been great to see the community there. The Utah Endometriosis group is spectacular, and we still have a relationship with that. And for the last 3 years, almost 3 years, I've been out here in Atlanta with the Center for Endometriosis Care, Dr. Sinervo in the group. And it's been spectacular just having the support, multidisciplinary support that was lacking a bit at my old place. It's just been so refreshing to be able to know what needs to be done and have the people behind me to support those decisions.
Yes, so it's excellent to have you all here tonight. I'm curious, and we'll do this as a panel. We'll let everybody have an answer. We'll start with you, Dr. Arrington. Someone comes to you and the person has cramps that hurt. Where do you begin? And it's like a 12 or 13-year-old.
I mean, first you take a good history. Just, when did the cramps start? How much do they impact them? We talked a lot about how it impacts their life, not only at school, but just being a teen. And if it gets to the point where those cramps are really impacting what that patient is able to do on a normal day, if those symptoms, those cramps, even if it's just around the time of period, if it's impacting what that patient is able to do at school and things that they want to do, then that's not normal. And I think that's key right from the beginning to know that that's not normal, and there's typically a reason for it. Now, what a patient decides to do, or patient and family decide to do from that point, really depends on the education, explaining what the goals of treatment are, what the possibilities of the cause are, and just make sure that we cover all of that and help them make a decision. But I think the key in the beginning, especially if those symptoms are related to the period, is to bring up endometriosis right from the beginning and be clear about what the implications might be as we consider treatment options.
Yes, and Dr. Orbuch, how do you like to approach the person that comes to your practice and they're 12 or 13 and they have horrible stomach aches with their period, which really was my story?
Yeah, so what's interesting is that the most common non-gynecologic complaint that people who have endometriosis have are gastrointestinal. And that usually throws people off because frequently, especially if it's a teen or an adolescent, they'll go to the pediatrician, who then maybe will send them to the gastroenterologist, and then they start chasing their tail and eventually do some testing, and then they just label the patient as having IBS and throw their hands up and not do much. But that is usually the hallmark of the beginnings of the endometriosis brewing, and usually will then escalate, to the more typical symptoms, when they go through puberty and menarche, and it is something that can't be ignored. And I think, speaking to something that Jeff had mentioned, when you take I always tell patients, they ask me, how certain are you that I have this? And I said, I get 85 to 90% of my certainty of my diagnosis just by talking to you, because and from after years of doing this, you see the patterns of how things develop. And one of the things that I always look at, and getting back to what I was saying, to reiterate what Jeff was saying, is when you have a teen or an adolescent or even an adult, you ask them, do you miss days of school because of this? Or if it's someone who's older, do you miss days of work because of this? And if the answer is yes, and it's pretty regular, that's just not normal. And there's no reason to just blow it off, so to speak, because that's not usual, it's not typical, and it shouldn't happen. And the proper thing to do is to then work things up appropriately to see what is the cause, what is the cause of all this. And many people tend not to explore a lot of the coexisting GI issues that, that they just randomly call IBS, and they don't work patients up to see if they have SIBO, small intestinal bacterial overgrowth, to see if they have some food sensitivities or allergies. These are easy things to diagnose and to start treating. And also to the patients who have very sensitive GI tracts who do have endo and other very inflammatory sensitive conditions, directing them to have a more healthy lifestyle, eating more organic foods, things that are not processed, not full of preservatives, everything to kind of clean up their act, so to speak, to make them feel better, because all these things combined will help their baseline state of being, get to a much better level. And then you can start treating these things even when they're 12 or 13. And it's not saying that you would jump and make the assumption that they have endo, but you want to make them feel better, and you want to stop all these aggravating things from continuing to percolate.
Now, at the Endometriosis Summit Town Meeting, that is our March 7th event, tickets are on sale. Dr. Arrington, you're going to talk a little bit about informed consent, one of your favorite topics. And so even on Instagram today, we talked about that most teens who go to the doctor, if they make it to the doctor, they're offered just birth control. What is the realm of things a teen could be offered?
So making, again, an assumption that the history is very suggestive of endometriosis. Let's start with that. So based off their history, they're missing school. It tends to come around the period time. They may have had bowel symptoms leading up to where the period pain started. So high suspicion of endometriosis. At that point, we just sit and we talk and say, look, all of the options, all the choices that we have to treat a patient with endometriosis include doing nothing. Just understanding that there's pain there, that this could be endometriosis and we can't predict what it's going to do. We don't know the state of it. We can't predict what it's going to do, but doing nothing is an option. Number two, moving on to medicines and the role of medicines, and explaining to them that the role of medicine is to control symptoms. And that includes ibuprofen, it includes Tylenol, it includes birth control pills, progesterone pills, IUDs, Lupron, or Lissa. Those medicines are only studied and only shown to treat the symptoms of endometriosis, quote, endometriosis-related pain. And then beyond that, we get up to surgical management. And typically in a teen, surgical management is going to consist of surgery for excision. There may be cases where you discuss hysterectomy, but I typically throw that out, but then push it to the side for most patients. From an informed consent standpoint, more often than not, patients present, the doctors say, okay, you have painful periods. They may not even bring up the word endometriosis from the beginning, and they say, okay, we just need to start you on the birth control pill. Without a discussion saying, okay, this is an option, let's choose the birth control pill and let's see if we can get you comfortable. Let's see if we can get you functional. And if we can, then that's great for a period of time. But while we do that, it's important for you to understand that we can control the symptoms, but we don't know the state of disease and we can't predict how this disease may progress. And I think that's important to understand that at some point there's going to need to be evaluation, whether it be by appropriate, mobility ultrasound, I call it dynamic ultrasound, something, or potentially diagnostic surgery. I feel it's important by the time they get to 20s, early 20s, before we expect that disease to be rampant and crazy, that at some point we get an idea of what the state of that patient's disease is. And I always used to tell patients, I've never seen a case of endometriosis that, even though it was more advanced than what I thought it would be, that we haven't been able to really treat appropriately before the age of 21. That's until I got the patient, a 15-year-old with easy stage 4 full thickness bowel disease, completely frozen pelvis, who had been precocious puberty, had been on Lupron for a period of time. So those extreme cases can happen. And it's just in our informed consent discussion, we've got to be clear about the implications of only treating symptoms while ignoring what may be going on inside. That was long-winded.
Right.
That's my answer.
Dr. Vidali, you treat silent endo. So people come to you and don't understand why they're not getting pregnant, right? Because you have a portion of your practice that's reproductive immunology. You always say to me, silent endometriosis really isn't so silent because the patient can always go back and think of their past. How many of your silent endometriosis patients really start to think about their teen years later on and realize what was going on?
I would say it's a great question, actually, Sally. Thank you for asking it, because one of the endometriosis presents itself in so many different varied ways that and everybody has a different story. But I would say that a non-uncommon story for some of the patients that I do see in their later years, they will tell you, well, right now I don't have pain, but I used to have a lot of pain when I was younger. And I think that in my teenage years, and I think that we always assume, oh, well, that's normal to have a lot of pain. And that's not the case. So actually, you're probably pointing out an interesting presentation, that of like somebody who had, and usually I can tell you the pattern is this in these patients. They had a lot of pain. Somebody put them on birth control pills, and the birth control pills helped some of the symptoms, and they stayed on it for a decade of birth control pills. Then they stop, and then because maybe they want to try to get pregnant, they're ready, whatever, they're in their 30s, and boom, now endometriosis sort of like raises its ugly head. Because it is true that hormones sometimes do help symptomatically to control the symptoms. They may not control the progression, but they do control the symptoms. So I think that's a good example, for example, of the different stages of presentations. But one thing I also wanted to add, perhaps, and ask to our panelists today, and it's also about informed consent, that I would think that the teenage patient, the young patient, presents itself herself, or whichever pronoun she wants to use, in different, she uses, forget what she wants to use, in a different way, because often there is the presence of their mother or the father, and it's a little bit different type of presentation. I don't know if our panelists would like to comment about that and how to interact on that level.
Yeah, I think my experience has been with the younger patients. The parent or parents are very, upfront and forward in the process. Many times they're the predominant voice in the discussion, and the patient themselves sits there very meekly and quietly. And I make it a point always to, in a polite way, to just stop the parents for a second and let the person who's actually experiencing this, speak their piece, because you don't always get the full extent or the true extent of what's going on getting it secondhand, even though it's apparent. I mean, they're well-intentioned, but it's really important to hear the story from them. And frequently, I will ask, at some point during the interaction, when I have a moment to address them, privately, I'll say, if you'd like to chat, without your parents, I'd be glad, to do that as well. So I think it's very important, especially in teens or who are in an awkward age socially, where they feel kind of, it's a lot for them to process. I mean, it's hard enough to be a teenager, but then to process having this condition where there's all this going on and there's so many things for them to consider, and then you're throwing the concept of surgery at them, which has to be frightening for them. So I think it's really important to, and I tend to over-educate my patients and families, because I think it's important, even if you're telling too much and they kind of get a little frightened when you do the informed consent about the potential issues and complications and what you may find, et cetera, and so forth. But I think it's best to be as prepared for every possible issue and situation, rather than just flying blind. But I think if I can just interject one other point to Dr. Vidali's comments before, is that people don't realize that probably upwards of 50% of women who have what they refer to as unexplained infertility have endometriosis. They've had the $1 million workup, and everything, hormones look good, tubes are patent, partner's semen analysis is normal, you know, normal ultrasound, normal MRI, yada, 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 yada. And they're not getting pregnant, you know, spontaneously or with IUI or IVF. And that the next step is to see what's, you know, physically and anatomically going on, because frequently, you know, it doesn't follow a textbook pattern. It's not like a lot of other conditions where you can correlate the amount of symptoms to the amount of findings, because we find, and I'm sure that my colleagues would agree, is you have the whole spectrum. It's like minimal symptoms, tons of findings, vice versa, and everything in between. And sometimes you get really shocked by the infertility patients who tell you exactly what Andrea was saying. I don't really have much symptoms, but then you start digging into the history, you do find it, and then you find all the other stuff, like, oh yeah, I'm like always constipated, or I pee 42 times a day and I get up in the middle of the night to pee, and I have to put my feet up on the toilet seat and contort myself to have a bowel movement. And they've been doing it for so many years. They experience what I call the new normal, which is not normal, but that's what they're accustomed to. So you really, that history is just so important. And, you know, and this is what I stress whenever I give grand rounds or lectures of any sort to practitioners, whether they be physicians, PAs, or nurse practitioners or nurses. It's like, just take that couple of minutes and ask these key questions, and that will uncover so much information.
So excited. I was invited to my first grand rounds in May. Anyway, so
real quick, Sallie, both Larry and Andrea, it amazes me. Remember back in medical school, how our very first structured clinical experience is a detailed patient history, and we go through hours and hours and hours on how to do a physical exam. And then we see what the normal is when we get out into practice. And I call this, you know, the annual exam pelvic, or the annual exam history, where doctors completely forget how to do an appropriate history, and their exam is cursory, similar to what they would do for any, you know, annual exam patient. Those two simple things with history and a good endometriosis based physical exam, how much that will tell you.
It's so true, and you see that in a lot. It's like the experience I think that most people have when they go to the emergency room. So they come in, they'll do a pregnancy test, an ultrasound, a CAT scan, a CBC, A, B, C, D, E. Normal, 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 normal. Patient is curled up on the ground in pain. They're like, maybe they'll give them some narcotics or tell them to take, you know, give them some ibuprofen, and they just go, everything's normal. Follow up with your gynecologist. And
they will tell the patient, Larry, that they had a rupture cyst. That drives me bananas. It drives me completely nuts, because, you know, rupture cysts really, I don't want to say they don't exist, but they're exceedingly rare. But every person that goes to the emergency room with some level of pain gets told that they have a damn, excuse me, rupture cyst. It drives me insane.
Right.
Insane.
Well, when they're told they have the ruptured cyst, then the local gynecologist can put them on birth control pills for 20 years. And then, oh, you had that ruptured cyst, you better take this. Right. Except the ruptured cyst is rarely the source of the pain. Let me ask you guys one thing, or I'm going to ask a lot of things. Let me ask you guys this. I think it's a myth, but this notion that teens have a hard time with their periods and getting used to their hormones, so they need to have the birth control pills to regulate them. What do we all think about that? Dr. Arrington.
I mean, when we talk purely regulation of the period, so we're not talking about pain, we're talking about controlling the timing of the period flow. I think it's common in the beginning. I always explain it, look, your ovaries are just barely starting to figure out what they're doing, and your body's trying to figure out how to respond to this. And there's going to be some fluctuation and some abnormality and some irregularity to the period. And that can even last for a few years from the time the periods start. But I think it's important, number one, to understand that that's pretty normal in the beginning, but also to understand that if it's super bothersome and if they don't like the irregularity to it, there are options that we can use to try to manage that, birth control pill being the most common one. But it's not something that has to be done, because really we're trying to, for the most part, that in the beginning, we're trying to use the birth control as a convenient prediction of the period, not necessarily correcting something that's abnormal. Does that make sense?
Right. I think it becomes a way for gynecologists who should be saying endometriosis, but not necessarily treating it to their patients, to sort of blow them off and say, well, your hormones need to be regulated here, take this birth control pill.
Well, there's a difference between the period regulation and are they also presenting with pain symptoms or endometriosis type symptoms. Irregular, correct me if I'm wrong, but irregular periods, heavy periods, those sorts of things are not really symptoms of endometriosis. That's symptom of hormone regulation of the uterine lining. Certainly, so if a patient comes in purely for irregularity, that's common in the beginning. If a patient comes in with pain, maybe also having some irregularity, then you've got to address, we talk about both of those. We talk about the irregularity, but we also talk about the pain, and we try to combine the different treatment options, or at least lay the treatment options out for each problem specifically.
Dr. Orbuch?
Yeah, I have to agree with Jeff. I mean, the birth control pill is kind of a go-to cop-out, if you will, for most GYNs and family practice docs, where they just don't know what to do. It's kind of that another Band-Aid that they throw on things. It's not, if it's just for cycle control, like, you go, and like Jeff mentioned, you're going to be, most people are irregular, for the first several years, even, when they start their cycle. If there isn't concurrent additional symptoms like extreme pain, a sudden, beginnings of these GI symptoms and disturbances and other kinds of pain symptoms, then it's really, then it's a matter of preference. Some girls want to be regular, and they just are bothered by, having their period come every 2 weeks, the last 2 months, and then it takes a break for 3 months and what have you. So, and the thing that most people have to understand, and I think you alluded to this before, Sallie, is that the birth control pill, pain medications, and then things like Orilissa and Lupron, they don't, if there's endo, it does not slow down or stop the progression of the disease. It's still there. It's like if you live in a climate like the East Coast, it's like your front lawn. It's there. It's kind of gray and brownish looking in the winter, but come springtime, it sprouts up and it's nice and lush and green. So that's all you're really doing. And that's why I like to, address the issues rather than mask them, and and I'm not personally, and I'll say it out there, I'm not a fan of Orilissa or Lupron, because I don't see the end point to that is really of no value to anybody other than the pharmaceutical manufacturer, because you can only take it for a very finite period of time, and then you're stuck right back where you started from, but now you have all the side effects of the medications you just took. So I think you really have to take 2 steps back and look at the big picture of what you're dealing with, what the symptoms are, what the likely diagnoses are, kind of put that, front forward to the patient so they understand, and they're kind of and this is one of my practice philosophies, I want them to be a partner in the process. I'm not dictating to them. I'm not telling them what they have or belittling them, because that's the worst thing you can do. You want to validate what someone's feeling and experiencing and really make them understand it. I mean, I not to sound corny, but almost every day I'll see at least one new patient that I'll see the look in their eyes of they're really, not feeling well, but there's this sudden epiphany look, that aha moment, like, oh my God, that all makes sense now. No one's ever explained that to me. Now I understand it. And even though, it sucks that I have this problem, at least I know why it's there, what you're going to do, and how we're going to help to resolve this. So that's really the important thing. It's to take that methodical, step-by-step approach with an endpoint that has real long-term benefit for the patient.
Sallie, can I comment on your question? Also comment on your statement. I think that what you just said is very correct. Because I do believe that there's a lack, I think, on parts of many doctors of I don't know. There's lack of knowledge, but certainly a lack of looking into whether certain patterns, whether they're ovulatory or pain patterns, are the result of a physiological process, which we understand, for example, that for the first couple of years, there can be anovulatory cycles from what are pathological patterns, such as abnormal pain, or, for example, polycystic ovarian disease. So I think that it is very important for doctors to distinguish these pathological patterns from a normal developmental trajectory. And I think if you just throw a birth control pill at somebody like that, here, take it, and you haven't done your analysis, perhaps you are delaying an appropriate diagnosis. So I would agree with what you just said, Sallie.
So I didn't realize until last week when I got about 50 emails about the Endo Summit Live. There are a lot of newbies that watch these, and sometimes this is the only education on endometriosis or the first education they get. So I'm going to ask this question, though. Our crowd, we always assumed our crowd knows the difference. Dr. Arrington, excision or ablation if you have to go to surgery in a teen? And what's the difference? Oh, you're muted. It's such a good question.
So excision versus ablation. Basically, the goal of surgery should be complete treatment of the disease. In my mind, I think the other two would agree with me, complete treatment of the disease. Now, could theoretically the endometriosis be completely treated by burning it? I think the answer to that is yes. The question is how do you know how much to burn, how deep to burn, how wide to burn, and how do you know when you get to the limit of normal tissue? And those are all questions that I think are very difficult to answer from an ablation standpoint. And aside from that, when you ablate or burn, you create a thermal injury to the area, which can contribute to higher pain, probably contribute to longer, risk of adhesions, that sort of thing, abnormalities in the tissue structure itself. So ablation is basically burning, trying to destroy the lesions by burning them. When that comes, and often we'll see doctors say, well, there was endometriosis over the ureter, or there was endometriosis over the bowel, so I didn't want to burn too deeply because I didn't want to injure those, which is true, but by doing that, you leave disease untreated. Excision takes the approach where we treat endometriosis like a dermatologist would treat a concerning mole. We want to get all the way around it and all the way under it, completely removing the diseased tissue, leaving only normal tissue behind to then heal over properly. I am a firm believer that excision is the better treatment. I can start in my normal margins. For the most part, I can tell if there's deeper disease that's attached to things deeper in the pelvis, in the sidewall, in the bowel. And if we need to just take the dissection, take the excision deeper to fully remove the disease, but do it in a careful, in a controlled way, and repair what needs to be repaired to make sure the patient can recover appropriately.
Now, a lot of people hear this in their practice all the time. It's usually the mother that says it. I don't want my kid to have surgery. The local GYN said the birth control pill would shrink it, which Dr. Orbuch already stated that's really false. What is the threshold? And I'm going to ask all three of you to answer. What is the threshold in which you consider surgery in a teenager? And is it age-based, or how do you decide if it's case-based? Dr. Orbuch, you go first.
So I think what I do, and this is not really just limited to the younger population, the way I approach treating all of these patients is you have to assess the individual. If there's nothing of any urgency going on, for example, a large endometrioma that you're afraid is going to rupture and just make a mess of everything, and they've been experiencing a lot of these symptoms for a long time, what I like to do is try to downregulate all these different pain generators that they've had for so long, to kind of calm down their central nervous system, to relax their pelvic floor and back and leg and abdominal wall muscles, to start treating their pain, but like to more normalize their pain threshold, and to also cool off their central nervous system with medications, like not narcotics, like gabapentin and things of the sort, to make them feel better and to make them better prepared for surgery, so they feel better and they can recover quickly from surgery. Then you kind of gauge what's going on. In a very young patient, you're not going to traumatize them by doing a pelvic exam on them when they've never had a pap smear or been sexually active. So it's really more so, the history and just the external physical exam. If nothing is really helping them that much with these more conservative therapies, and their symptoms are just continuing to escalate, and they're just absolutely miserable, and they're missing, X days a month from school, then really you're at that fork in the road where there's only one option, and that's to do a laparoscopy and see what's going on. And like Jeff was mentioning too, until, I think we've all experienced this, until you saw that young patient with more advanced disease, once you're in there doing a laparoscopy, you realize that, again, getting back to what I was saying, there's no set predictable pattern of the behavior of endo. So you don't, you want to intercede or intervene when it's appropriate for that individual. So I think optimizing them, making them feel better. If they're, sometimes, if they're in school, it's not really convenient to do surgery on them in the middle of the school year, unless it's around the time when they have a break or something like that. So you can coordinate that based on what will be least disruptive for their lives, and then do things in the proper sequence. But surgery is definitely, there is the option to go to when things are just intractable.
Dr. Arrington, what is the threshold for surgery for a teen, in your opinion?
So number one, it's an option that's brought up at the first visit, but I think it's fair to give a patient a chance, if they've never been tried on it, a chance at simple hormonal control. Again, trying to find in the young patient where we really don't expect super advanced disease, to see if we can just get them comfortable. If nothing else, it allows them to continue in their schoolwork, it allows them to continue in their activities, and potentially might allow that disease to, quote, grow up a little bit, so that when they do have a surgery, it makes it more easily identifiable. But if a patient fails a trial of a birth control pill or a hormone, I don't see a whole lot of benefit in trying to find a different one, what we call hormone shopping, trying all of these equivalent medicines to try to magically find one that's going to make them feel better. Even if you look at the ACOG bulletin, the general bulletin on endometriosis, it states that the birth control is a first-line treatment, but that surgery may be considered, laparoscopy may be considered if that initial treatment fails. Most doctors completely skip over that part and don't even offer it. So if a patient has been tried on birth control and their symptoms are not controlled, they're still missing school, they're still not able to do what they want to do, then to me, surgery maybe needs to be more of a discussion in that. I do not think it's fair to just tell a patient that they need to suffer through it until they're older, or to get pregnant as a teenager, which they're told.
Right. Well, and Dr. Vidali, we'll have you answer the same question. What's your threshold for surgery in a teenager?
People come back and they come back with the same problem. You sometimes recommend hormonal treatments initially. I'm not against it. I think it's appropriate, unless there's clear evidence of physical evidence of disease. and people come back and they're not functional. They're not functional in their life. So to me, when people come back and keep on coming back, for me, that's a sign that, surgery is required. Unless, of course, I'm like the fifth doctor they see. That's like a different situation, of course, but in general, that to me is a sign that things are not getting better, because people get in the car, they drive 2 hours, they drive 3 hours, they're back there in front of you. I think that's a sign that something needs to be done.
And I think as we start the hormone, part of that discussion is very clear. See, look, we're going to try this, but I want you to know that this is just a trial. And if it doesn't work, I don't want you to just think that you've got to deal with it. We need to talk, and there's some other options. Yeah. And there's other options that need to be discussed, but that has to be part of the plan going forward. If it works, you continue it. If it doesn't, then we need to talk more.
Right. And I started my career seeing a lot of the Orbuch's patients, or when I started my practice, and we have a lot of physical therapists that watch us. And as a physical therapist, you need to take responsibility that if your patient's pain isn't improving and their dysfunction isn't improving so that they can live their life, you have to send them back to the doctor. It has to be a continual open team conversation. Now, Dr. Vidali, is there anything we talk about sometimes, the suffering Olympics? Is there anything about operating on a teen that feeds that? We really have open discourse here. I don't want to ignore the bad sides about operating on a teen.
Well, obviously, first of all, once somebody operates on a young person, you have to understand that this person is, every patient is vulnerable, I would say, but I would say that a teen patient is even more vulnerable. And I think, these early experiences in life can be, can set the stage for the future, and they can be very traumatic. They can set the stage for future behaviors. So I think that a lot of considerations has to be placed into this. So, and like I said, I don't believe I believe the surgery is surgery. So when you do an operation, I don't think the age of the patient really matters. The objective, the goal should be the same, which is, obviously, just because somebody's young, you're not going to go there and do the surgery gingerly and leave disease behind because you're more worried about the fact that the patient is young, which I see a lot of that, unfortunately. But nevertheless, some consideration has to be made to the age of the patient and how these experiences can mold the personality of a person. And perhaps the same way that we recommend physical therapy, also other support should be provided to patients, to all patients, but more particularly to the most vulnerable, which I think are the youngest patients.
Now, you talked about you wouldn't change the surgery. I've had this conversation with Dr. Gargiulo, who is also our faculty member at the Endometriosis Summit. Tickets are on sale. So Dr. Vidali or Dr. Arrington and Dr. Orbuch, do you operate differently around and on the ovaries of a teen?
So I can say that, like, my philosophy always is, don't touch what's not involved, because there are many studies looking at what trauma to tissue just by grabbing it with an instrument can do as far as being a nidus for adhesions and scar tissue. So I think, the objective always is, I always say, is to tread lightly and leave very little footprint of your presence other than that which you really need to do. So I think, in younger patients in general, you are very, cognizant of that, and you want to do as little trauma to tissue as you can. But like Dr. Arrington was saying, you want to do a thorough excision, because, the way that I look at it is the most likely way for someone to have one and done surgery is to do excision the first time, the right way and completely. And, part of the informed consent process, you put forth what the possibilities of what you're going to find and what you're going to do and what the patient is okay with and what they're not with. So I wouldn't say, if you have no suspicion of or imaging studies or any indications that there's, an invasive bowel lesion, for example, you're not going to be doing a bowel resection. So you're really, you want to educate but not terrify the patient, but you tell them, I may find X, Y, or Z, and you tell them what you are planning on doing, and they can also tell you, well, I don't want you to do this or that. But in general, my philosophy is you want to do it right the first way. You don't want to, leave things behind to increase the likelihood of them needing surgery again in the future. So, and that's one of the things I think is unfair. There are people out there who operate on patients and tell them, oh, you're going to need multiple surgeries. It's very demoralizing to the patient, and it's really, especially to a young patient. But I think you really want to do the best you can the first time around.
Especially when they do those surgeries and they knowingly leave disease untreated, right. And then they have the patient back in their office and say, look, we treated most of it, or we treated some, or we made the diagnosis. Now let's go put you back on those hormones that haven't worked for 10 years. Right. It blows my mind how often that happens, that they completely forget the patient's prior history and their non-response to hormone that got them to surgery in the first place. And the answer is, let's go back and try all that again.
No, and I think that's what I see a lot in patients who've had surgery elsewhere, where they've done some sort of ablation, and they don't quite they can't understand why. I just I had this surgery 3 months or 6 months ago. Like I'm in the very same place. No one's ever explained to them exactly what Jeff was talking about before, and this is the pitfalls of ablation. Is you're basically treating what you can see two-dimensionally. It's the surface. It's the tip of the iceberg phenomenon. You don't know, is it 2 millimeters at the surface and 8 millimeters deep? And what you're doing is you're burning something and encasing the endo with scar tissue and thermally charred tissue on the surface, and now they have all this percolating below the surface. So of course they're not going to feel better.
Melting the iceberg with a blow dryer.
Right.
Sallie, with respect to the ovary, if I see a teen that has endometriosis in the ovary, if regardless of the age of the patient, if they want to keep their ovaries, I treat the ovaries the same. I'm still going to go after the disease. I want to go after it in a way that's going to limit the damage to the normal ovary. But whether the patient is a teen or 20s or 30s, if they want to keep the ovaries there, as long as it's reasonable, I'm going to treat the disease on the ovary the same way, just be as judicious as I can and minimize trauma to the normal ovary.
Big fan. Once you hit, ovaries should be maintained in the body for all sorts of reasons of other health than just the ovary. Also, I'm not a big fan of removing ovaries without understanding how much in your body really drives pain. Dr. Vidali, in a teen, you treat the ovary the same or different?
Treat the same. In my opinion, the disease should be treated the same regardless of the age. So the principle that, and I think Lawrence obviously agrees with me, Larry agrees with me, the principle of respecting tissue applies to every age regardless, I think, and the principle of radical excision regards, at any age should be applied, in my opinion.
What do we think that the studies out there now, we are having a big debate at Endo Summit Surgery between Dr. Redwine and Dr. Martin and Dr. King and Dr. Iglesia, but Dr. Martin and Dr. Redwine. So I've been reading all their stuff all day. What do we think about the studies? What kind of damage or elevation, the studies that show that we should put people on birth control until they're ready to get pregnant? What do we think that has done for the teen endometriosis community? Dr. Arrington, you start, because I know you're ready to start.
So number one, that makes an assumption that every patient is going to be functional on the birth control. And again, I have a big problem with doctors telling their patient, put you on the birth control, and if that doesn't work, you just got to suck it up until you're old enough to get pregnant. Because for some reason they have this big adversity to going in and doing a surgery. So they make the patient suffer through. Now I totally forgot what the question was, Sally.
The question was, there's
You
research
stopped
that
at number one.
just shove them on the birth control pills and say, don't have surgery till you're ready
Yeah,
to
so
get
I mean,
pregnant.
the other thing that it completely ignores, like Larry brought up, is we cannot predict the course of the disease. And if we just throw them on birth control and say, stay on this until you get pregnant, number one, we make way too many patients suffer through with pain. And number two, we get way too many patients 8 to 10 years down the road that now have what I call destructive endometriosis that could have been dealt with earlier. And really, I believe if we catch these cases early, I really feel that we can prevent most of the cases of that destructive endo from hitting those patients in their early or mid to late 20s. So we make them suffer through with pain, and we ignore the potential progression of the disease.
And I believe as somebody who has the disease, we ignore their potential as a person.
Yes.
We do that. And I'm sure every doctor here that's volunteering their time to me tonight agrees with that. So there's also a theory that in young people, because endometriosis emerges as you become hormonally reactive, that the disease is not has not fully taken hold, and that a teen sometimes needs to fully hormonally mature before all the endometriosis can be seen, or the other side of it being that a teen may need repeat surgeries. Dr. Vidali, do you have any opinion on that kind of theory?
Well, I would say that it's not a completely wrong principle. You know, part of it is that we know that the appearance of endometriosis is different in the earlier phases of reproductive life. Whereas in the more mature person, we will see the typical inflammatory red lesions and the black, the chocolate cysts and all that stuff. It's more likely in the younger person to see little vesicles that are, very, very small, and it's a non-classic appearance, and which it's a kind of an immature appearance, if you will. And so it is conceivable that some of those smaller areas may not be totally fully visible or not mature enough to be visible, even with the magnification of the laparoscopic device, and that a few years later, lesions that were not visible at the time may present themselves, which, in my opinion, is one more reason to, if you're excising endometriosis in a very young person, to try to take a larger margin so that you try to avoid this type of process of sort of like newly formed lesions that were not visible. But I'd like to hear from our fellow panelists what they think.
Yeah, I think it's very key, and that's I think one of the the foundations of my general philosophy is you have to know what you're looking for, and if you're not really experienced treating the full spectrum of endo, age-wise and appearance-wise, you're missing the boat a lot of times. And if you show 10 gynecologists the same image, of something more subtle, 7 or 8 of them may say it looks normal. And
nine of them will say,
right, I'm being generous.
Yeah.
So you really, it does take on a very, very different appearance, and some things that seem very subtle could be missed by the untrained eye. But I think one of the other things that was really hallmarked there was a study from Italy several years back where they did autopsies on miscarriages of female fetuses. And they found that the incidence in a fetus of the findings of implants of endo already intra-abdominally was upwards of 9 or 10%, which is pretty much identical to what the percentages of endo affecting the general population, alive and well, as well. So it kind of really sheds spotlight on how it's not something that necessarily always sprouts up suddenly when you're a teenager or a young adult. It could be there from day one. So the whole etiology, whether it's metaplasia or environment, toxins, genetics, it's usually a combination of factors, and you can't really dismiss, the severity of someone's symptoms just because they're 12 or 13. And so I think it's really, it has to be, looked at very carefully.
It's interesting that this is one area where ACOG actually agrees with us.
Yep.
If you look at their teen endometriosis bulletin, they recommend that a teen should have surgery by a specialist who is familiar with presentations of disease in teens. It's not too often we agree, but that is one thing that they point out.
What we don't agree is who the actual specialist is.
Yeah. Yep.
Because, and this is like, it may be a little controversial, and I may ruffle some feathers, but we like ruffling at the Endometriosis Summit. But a lot of, adolescent gynecologists, sometimes I would say do not have endometriosis as a major focus there, and certainly not treating endometriosis as a major focus. And I think that it's a problem, in my opinion. I don't know how the panelists maybe are more diplomatic, but
I mean, they go in looking for the classic blister lesions, the white blisters, the red blisters, the blue-black blisters. And take for example, a blue-black blister. Their treatment of that is to go in and burn or laser the blue-black fluid and completely ignore the tissue underneath that created the fluid. I mean, as far as teens go, Andrea, you mentioned, the clear vesicles. When we get those pictures, especially in a teen, where the pictures are zoomed out and they lift an ovary and take a picture from the belly button, it's completely zoomed out. You're missing the clear lesions. I see all the time what I call either ulcerative lesions or little halo lesions. And then I do a lot of comparison of tissues. If I'm looking at the pelvic sidewall, if I see an area that looks completely different than everything else around it, to me that has a potential of endo. And sometimes just that subtle of a presentation can make all the difference in the world to go ahead and excise that and remove the disease.
We're running out of time. I can ask one more question to the panelists.
I was going to actually ask our panelists to say 15 minutes extra. Can people do that, or you can't do that?
Sure.
Yes.
Yep.
Okay. All right.
Can
So
I
Dr. Vidali, ask your question. Don't feel rushed.
Yeah, there are some difficult cases though when it comes to young persons, and this is kind of changing gears a little bit, changing a little bit of topic. I do see, in my practice, a significant number of young persons who have been sick since they were very little, especially with gastrointestinal problems. They have autoimmune conditions. They also have pelvic pain. So they have a number of problems that they have been living with since they were some of them very little. Chronic constipation. And by the way, I'd like to mention a phenomenal gastroenterologist, Dr. Larry Orbuch, who happens to be the brother of Dr. Orbuch, and he's like really one of the top gastroenterologists in America for endometriosis. I have to say that.
He was trained well.
Yes. And sorry for the digression. And so some of these persons may have endometriosis, but their problems are larger than that. And they are, I think, a great challenge to treat. And sometimes they don't have endometriosis because they have sort of like a more global autoimmune chronic type of situation, I think. And I don't know, I'm curious to know if the panelists have seen those, because these are very difficult situations and very challenging circumstances.
Yeah, I've seen quite a few patients like that, and they generally will have, autoimmune thyroid disease, Ehlers-Danlos syndrome, a whole myriad of issues. I think just you look at any problem.
I just don't want those patients to believe that just taking out the endometriosis will solve the problem. I want to make it very clear, because we don't want to give this impression that excision is the solution to all.
Exactly.
There are additional problems sometimes.
You have to dissect out what's likely and what's improbable to be causing particular symptoms. I think, some of these people are in a little bit of a nebulous zone because, they've been blanketly diagnosed as fibromyalgia and then subsequently maybe endo. And so there's a lot of overlap. So I think it's really getting the other things as under control as possible, with the realistic expectation of what you think you can conceivably help them with is really important, because I think expectations are really important to get in the right zone before you treat somebody, because then it can be realistic, or it could be unrealistic in thinking that it's a panacea, that your surgery is going to treat everything.
Sallie, how do you feel about that? I'd like to hear your opinion.
I think that the surgeon that thinks they're God has no role in treating the teen, because they can never be realistic about what the experience is like, and that they promise things because of their own personality that maybe is not going to be delivered in the teen. And then the other thing to think about is, that teen needs to get into some kind of situation where they learn empowerment over their pain. If they are like, fibromyalgia, they have, even though they probably don't have it's pain all over their body. It's not just go to pelvic PT, it's work with somebody who's on your team, who's able to develop what's going to work for you for your life. And it certainly isn't just saying to that patient, go do yoga, because like the Ehlers patient, probably not a lot of yoga. The same way I do a ton of groin and hernia work, not a lot of Pilates in that crowd. So like, there's no one answer. Sometimes we used to say, just go swimming. There's actually no research that demonstrates that's better for pelvic. So I think it takes a multi-pronged approach. And one thing that when we sit here with probably 3 of the best specialists in the country, let's talk about the little girl who can't access care. And how do they talk to their gynecologist about what's going on with them? Let's talk about that teen. What are suggestions for the person that has a lot of trouble accessing care, or gets stuck in the loop of the primary care doctor telling them to take Tylenol, and did they try gluten-free? What do we say to that young person?
Well, I think one of the important things is to really educate not only physicians, but different like healthcare practitioners to identify these problems rather than passing the buck around. Because I think we've all seen the patients who come in with a myriad of complaints, who probably have endo, who I can even predict before they even start talking, because I've looked at their medical records. They've seen every kind of specialist under the sun, and everyone like does whatever test and evaluation. They throw their hands up, and they gets punted to the next doctor. So it's the GI, the urologist, the rheumatologist, the pediatrician, back to the gastroenterologist. It's all over the place. And what I think most of us have experienced when you give lectures to different specialty departments and grand rounds, et cetera, they look at you like you have 4 heads. They've never seen the connection between a lot of these things, so they don't really they don't guide the patients or channel them properly to the right places, and it becomes exhausting for the patients, because especially for the teen, because they're teens, they're in school, they want to have a social life, and to be sidetracked going to this doctor and to that doctor and to this treatment and to that test, it's completely abnormal for them. And then they kind of run out of gas, and then they just give up. Either they give up or the parents give up and they throw up their hands, and then the kid is suffering. And I think that's education is so key, and the level of awareness is just still not anywhere near where it needs to be. It's better than it was a couple of years ago, or a decade ago, but I think it's just that the generalized awareness needs to be really kicked up multiple notches to a place that it should be.
And when the teen suffers, it changes the way their personality develops.
Yeah.
It's not like, if you're gutting through the worst 5 years of your life when you're 35, it sucks. I'm not going to say it was great, but your ability and like all your synapses are formed and your personality is there already.
Yeah.
To just be brushed off all the time, it really changes the
Yeah,
person.
absolutely.
Yeah.
But-
Dr. Arrington, it changes something else. A lot of these things that doctors do to teens, now they hand them Orlissa. Can you talk a little bit about, and we certainly can do this in the summit because Dr. Arrington's talking about teen endometriosis, but you always talk about, with me at least, when you deal with teens, what it does to their bone development and to their future health in their lives.
So number one, again, I'm going to bring ACOG up right at the beginning of this. And if, again, you read the ACOG bulletin, they do discuss Lupron, but they discuss Lupron after surgery in a teen. That's ACOG. Now, what we're seeing in real practice is these doctors are skipping that surgical part. And there is a huge push. It's the new, soup du jour. It's the new drug to just throw out because I can't think of anything else. Well, here, let's put you on this medicine without even a diagnosis. And again, we're putting patients on a medicine that, number one, is only meant to control the symptoms of the disease, does not prevent progression of the disease. In one head-to-head study was no better than a Depo-Provera shot at controlling the pain of the disease. It interrupts bone deposition in the absolute most critical time in a person's life to put on bone density that has to last them 7, 8 more decades. And we're blocking that bone growth with a medicine like the Orlissa or like Lupron without ever even having a diagnosis and without even really discussing the other options with the patient. Again, that is a major informed consent thing for me. Like Larry, probably Andrea as well, I would never consider using that in a teen. I just don't see a benefit when head-to-head studies don't say it's any better than what we already have and stuff that can be used forever. And when you look at the doses of Orlissa, the only one that was really even remotely beneficial was the 200 milligrams twice a day, where 75% of the patients couldn't even handle the side effects of it, and it can only be taken for 6 months. But I mean, I just saw a patient in consultation this week, a little older than teen, but had been on Orlissa for 2 years. And I don't know any study that has ever been shown to approve Orlissa use for 2 years. But they're making this push toward make a diagnosis based on history, but continue the same treatment that has failed patients for decades.
Now, keep in mind, we don't filter anyone. I'm going to ask you all to answer the same question again. What needs to happen in order for the teen patient to be heard and taken seriously instead of passed around and blown off? What on a societal level, on an ACOG level, or even on a pharma level needs to happen? Dr. Orbuch, kick us off.
Well, I think one of the things that needs to be addressed and really identified and spotlighted is the fact that endometriosis affects, to my knowledge, as many people nearly or exactly as diabetes. But the amount of attention, research funding, and general significance is not really paid to this condition that affects 10+% of women. And until that happens, it's like any other real massive movement in awareness in healthcare, like breast cancer awareness, the AIDS movement. It really needs to get bumped up, high up on the list in order to get that attention. And I think then that would be a really important starting point to making it more, to changing the whole landscape of diagnosis and treatment of this very common condition. And it's still, I see it all the time. People will, you tell them, you say the word endometriosis, they look at you like you have 4 heads. They've never heard of it before. They don't know what it is. And even among, forget about patients, even among doctors. I mean, they know that little small paragraph that they read in a textbook in medical school that had the information that they taught 50+ years ago, and they talk about retrograde menstruation. I mean, that's the extent of what they know. So it's really, it's not, the information, the awareness just isn't where it's supposed to be. And until it's right in front of people's faces, I don't see a massive change focused on it.
Yeah, Dr. Arrington, what do you think needs to happen in order for endometriosis in the teen to be taken seriously?
A few things. One, I think there needs to be clear directive from ACOG to regular OBGYNs about the roles of the different treatment options. That it needs to be stated clearly, and it's again, their two documents are contradicting. The teenage one says part of the goals of therapy is to prevent progression, whereas in the regular bulletin it states that hormones don't prevent progression. There needs to be clear directive of what the role of hormones is, to clearly state that it's only palliative, it's only meant to control symptoms, and we still need to worry about disease. And then from a separate standpoint, you look at the pharma influence in research dollars coming from pharma. And it is very clear as you watch TV, as we look back at the Speak Endo campaign, all of these things are geared toward, quote, raising awareness of the disease. But the purpose of raising awareness from the TV commercials, from the Speak Endo, or Lissa AbbVie campaign, is not to treat disease, it's to raise awareness of the disease, and then all of a sudden know, oh, hey, I can go over here and take this medicine. So the whole motive behind raising awareness is pharma driven, as opposed to understanding disease and treatment of the actual disease. That we're gearing just, hey, let's help you control your symptoms, without really understanding what's causing this to all happen. And finding
Right, we had a little hullabaloo on Instagram during last week, and it was somebody who was very well educated and very pro pharma, and then you can look them up and see how much money that they're getting from AbbVie, and it's like, please feel free to have your medical management opinion, but I just would love it to come from an unbiased position where you weren't paid to have that opinion. Dr. Vidali, what do you think needs to happen in order for teen endometriosis to be taken seriously?
We need more specialists, number one. We don't have enough specialists. Training has to increase. I don't think that MIGS fellowships are very good at training people in endometriosis. I have to say that. They may teach people about the skills, but many MIGS fellowships are focused on fibroids, urinary incontinence, and you name it. But certainly, teen endometriosis is not one on the top of that list. So I feel education, even in the areas that we deal with, is not very good. You could see that we need more specialists. Look, your speakers today are three older guys. I mean, some older than others, and males. And so, this is also a problem. So I think that a lot of things have to change, Sallie. A lot of things have to change.
Right. So I will say, with the Endometriosis Summit, you will see over the course of 3 days that we did our best to push not only to get younger surgeons, even though they may not be names you ever heard of, but we really tried to get a lot of female surgeons. But we're always held with endometriosis that if you don't have the skill set that you need to do a really good job, it's hard to present with us. So that said, I go around every single endometriosis summit live and I talk about, what are you looking forward to at this year's Endo Summit? This year's Endo Summit will be held March 5th through the 7th. We are selling tickets. We are introducing Endo Summit surgery, where there will be a live surgery moderated and you can ask questions while they're operating, right? That's very exciting. Dr. Arrington will talk about teen endometriosis, and we will have Team Orbuch do evaluation of endometriosis. And then we also have Endo Summit workshop on Saturday. And of course, our town meeting where everything gets talked about. So, Dr. Orbuch, what are you looking forward to the most about Virtual Endo Summit 2021?
I think what I always look forward to is the open discussion of issues, the propagation of knowledge, hearing what patients think, and really kind of stirring the pot to amp things up, to a better level and to achieve the kind of goals that we have, like my colleagues were saying, of getting true awareness out there, not pharma-driven awareness, increasing the number of practitioners out there who can effectively treat this problem, because that's still a pitiful few, and really just take it to a different level.
Right. This year's Endo Summit, we have not only live content, but hours of recorded content. So you can just sit home and watch endometriosis for the full 10 months you have access. But also, because we held it in a custom platform, you're going to be able to point and click at attendees in the audience and chat with them directly. It's going to be, and we have a live feed of social media. So if we're not getting to your question, you'll be able to tag us and ask questions that way. Dr. Arrington, you're a first-time participant, and I really wish we were in person, but we're not. What are you looking forward to about Endo Summit 2021?
So a few things. Number one, I always, and I'm just weird this way, I love opportunities to rock the boat. And sometimes I push that a little bit too hard, I think. But it's me, I enjoy doing it. And two, I also like going in understanding that I am very headstrong when it comes to this. I like the fact that there's debates like Dan Martin and David Redwine, people hopefully on my same panels that can push back and really make me step back and think, do I really believe what I'm saying? Do I really believe what I believe? And try to challenge my thought process and make me think deeper, make me look for a deeper understanding about how to help the patients. And then clearly, Sallie, this is the one endometriosis format that brings every player in endometriosis into one place. It brings the providers, it brings physical therapists, it brings social work, it brings patients, it brings advocates, it brings everybody to the same table and gives everybody an equal voice to discuss the issues that they're familiar with.
Yeah, it'll be very exciting. And because we're virtual, we're able to have even more amazing advocates. Like we have Donna Chica from Endometriosis Australia able to give a workshop this year because she doesn't have to travel to Hoboken. Dr. Vidali, what are you looking forward to about Endo Summit 2021?
I'm looking forward for the Endometriosis Summit to introduce new faces to the world of endometriosis. And I think we will introduce quite a few, right, Sallie?
Quite a few we've met along the way.
So I think that's going to be very exciting. Not new to us, but I think new to,
new to other people.
Audience.
Yeah. So tickets are on sale. Next week, we bring in the advocates. And we only have 2 Endo Summit Lives left in our Endo Summit Live season. And we did put the feelers out. If we get a decent sponsor, we'll do a summer season also. But we have 2 weeks left. Next week, we're bringing the advocates and we'll be at you. Now, my Zoomers, if you want to volunteer to do something for the summit, just stick around after I shut off the feed. But thank you everyone for joining us for teen endometriosis. And it was awesome to have you and awesome to see my friends near and far.
Bye, thank you.
Thank you all.